let me start by saying, on behalf of Mitch and myself, that we hope everyone is well, and we know everyone is busy, and we are very much grateful for everyone's participation on the call here today. And let me say at the outset that all the functions of ECOG-ACRIN are performing well, and it's thanks to the work of many people in our offices in Boston and in Philadelphia. And I'm not going to try and name everybody, but many people are coming together to make this a seamless transition into the COVID era, which we certainly hope will be coming back out of very soon. Now, we, of course, have been in touch regularly and frequently with the community leaders in ECOG-ACRIN. And Matthias Weiss is here today and represents the community. But we also wanted to reach out to community participants. And the purpose of this town hall is to say that from the perspective of our studies and our resources, we're here and we will do what we can to help. If people see a need that we can fill, please let us know. We also wanted to have the opportunity for an information exchange. We kind of know what's happening in all of our own areas. For Mitch and me, it's in an academic center, and there are some large community centers that we've talked to, particularly as part of NCORE discussions. But in the community generally, we have less information, and we would be very happy to hear back from you about what's going on in the community and how we can, again, be helpful. And Al Benson is going to provide some perspective on this from information from ACCC later on. And at the end of a few presentations in this part of the meeting, we want to have a bidirectional question and answer session. We're going to put a frequently asked question resource up on the website, and we'll continue to use that to communicate. But please feel free to communicate with myself or Mitch or anyone in the organization if you think we can be helpful. A couple of reminders at the end: make sure you're muted and get the cameras off. And if you have questions during the presentation, the email is below, townhall@ecogacrin.org, and we'll be delighted to get questions, and we will answer as many as we can in the time allotted here. We are aiming to finish on time at 2 p.m. Eastern Daylight Time and correspondingly across the country. Next slide, please. And so this is the agenda. I'm making some introductions here. Bruce Giantonio will talk about how the trials may need to be adapted in this COVID-19 era and the regulatory implications. I know that you've received some of this information already, but we will hit some of the high points. Matthias has been interested in the remote consent process, and there are details of this that we want to share with you. Lynn Wagner has been very keen to discuss some of the emotional support resources that can help everybody at this time. And we are grateful for her for preparing a presentation with these resources that we think could be helpful in the community as well as in academic centers. As I mentioned, Al will talk about the ACC feedback, and then we will go to the question and answers. Next slide, please. So I'm giving you a brief overview of the operation, support, and guidance, and will make a few comments. And I know that you've received a note from Mitch and me that a couple of these that went out over the last some weeks. But essentially, this is just to emphasize that everyone in our offices is working remotely. We have virtual meetings, probably are having more meetings now than we ever did when we were all in the same place. We have SOPs that have been adjusted to these environments, and we have a regular program of announcements to assure communication. And phone lines and fax machines have been rerouted next. We have an advisory group that has been assembled and consists mainly of the group operational and academic leadership, with a listserv to answer questions and track responses. And there's the email address, as you see there. We're having weekly calls with the NCI, with CTEP, Meg Mooney, and Walter McCaskill-Stevens, and NCORP. And these calls discuss the most recent developments and address issues that arise, some of which we'll be able to touch on as we go along here. There are guidance documents that you've received especially from the FDA. The FDA one is the most important, and there are some from CTEP and from the NCORP. And I will say that we are working very closely with the other groups in the NCTN to make sure that what we're doing is harmonized across the groups, and that our interaction with our membership is entirely consistent across the whole public system. And that we have additional announcements from central laboratories with study-specific guidance that have already been circulated. Now, what we're developing is protocol-specific deviation guidance documents for each of the major protocols. We certainly don't want to crash your email by sending you all of these individually. So we're going to post them. We'll let you know when they're posted. We think that the deviation guidance documents are essentially going to be very similar. From one protocol to another, you're not going to really do things that are wildly different. So we should be able to give you the most common issues that will wind up on these guidance documents, and we will share those with you as soon as we've assembled all of them. Next slide. And just again to show you the screen on the ECOG-ACRIN website for information and resources, and that's where the FAQ resource will reside also, so that if there are questions and there's nobody available to answer them, the question will probably be found in there, and if it's not, we will add it. Next slide. Okay, quickly to the group meeting, and very briefly, we had planned, of course, April the 29th to May the 1st in Baltimore. On the advice of the executive committee, we had hoped to make a virtual set of presentations. Over the summer, we will hold, we've invited the committee chairs to hold a 2 to 3 hour webcast, and that will summarize major activities and new activities in the committees. And, it's important. We want community participation in these webcasts. And so we invite you to contact the committee chairs that you've been most involved with, so as to ensure that you're on their mailing list. There's the potential for a leadership retreat in late September with the committee chairs and co-chairs, and we're hoping that that's going to be possible. Of course, much is up in the air right now. Even the fall 2020 meeting, we're hopeful that this is going to go forward, but nothing is certain. Next slide. And so a couple of general issues. Next slide. And so these are a couple of things that are in the hopper that we thought we would want to share with you. And of course, first of all, is the realization that in the landscape that we're in, all cancer treatment is a deviation in this environment. There are research questions that are being discussed that are relevant to patients and caregivers. And, you know, many of these questions can come just as reliably from the community as from academic centers. A potentially important idea came from P.J. Flynn just a couple of days ago over the weekend, where he raised the possibility of a treatment for patients whose respiratory status is deteriorating. So there are several interventions that one may think about. Some of these that are of interest in dialogue with CTEP are questions about less frequent immunotherapy dosing, particularly for Pembro, interventions to protect healthcare workers. And these are being developed in institutions, and some of them may be developed through the groups. There's a natural history study from the NCI, and that's projected to come to us in the next few days. In the community, there will be credit for accruing patients to study the natural history in patients who are on treatment for cancer. And now I just wanted to show you the accrual. Of course, the accrual has gone down. Next slide. And that's to be expected. But maybe, and there's two slides here. One is the intervention steps. And you see that for therapeutic studies, there has not been an enormous decrease in accrual, such as one might expect. And this has been very encouraging. You know, it kind of supports the idea that our trials have state-of-the-art treatments for patients with cancer, and that they may, in many cases, represent the best treatment for patients with cancer. And so we're committed to keeping the trials open as much as possible, keep the development of new trials coming, and this is what we're working for. Next slide. The screening studies have taken more of a hit, as you can imagine, and as you see here, and particularly some of the big accruing screening studies, such as TMIST, have decreased. And you know, we recognize that that's appropriate, that screening studies of their nature are less urgent than treatment studies for patients with cancer. But again, continuing accrual to these is also possible. So next slide, please. So let me hand over at this point to Bruce Giantonio to talk about some of the regulatory aspects and changes in trials that we all recognize now as being allowable.
The next slide. So as Peter mentioned, there has been a number of guidance documents issued, and we have them posted on our website. You can also find them at the CTSU website, and the CIRB also has some materials on their website as well. And pretty much there's a fair amount of overlap amongst these documents. They're all addressing the adaptations that are being allowed to the trials to accommodate the COVID-19 pandemic and the limitations on resources and the safety protections that we all have to put in place. So again, these are all pretty much similar, you know, across the different organizations that have issued them. There can be some differences in them, and I'll say right now that, you know, our position is going to be to take the requirements that are least burdensome on this site in terms of what's required to meet the adaptations. So as long as we can do that, that's going to be our position. And I also encourage you to make sure that you verify with your own institutions their guidance documents and whether there's any conflict with ours and how to rectify that conflict. There are regulatory implications for this. Next slide, please. So the motivation behind the adaptations is principally the safety of the study participants, as well as our safety as well, and the safety of our staffs at the institutions. But we have to keep in mind that the study integrity when we're thinking through some of the adaptations that we're going to undertake. Key to all this is going to be documentation. So documenting all instances of and reasons for variance to the protocol in the patient's record, because there are going to be still reporting requirements to the IRB. For the CIRB, for the studies that are under the control of the CIRB, we will have to submit a compiled log, and we'll handle this, of all the minor deviations that have occurred to a particular study at the time of the continuing review. There will still be major deviations that will occur, and these will still need to be reported either to the CIRB or to the local IRB according to the standard expedited reporting processes for major deviations. For studies that are handled by the local IRB, you would need to verify with them how they want the minor deviations reported. I suspect they're going to use this similar mechanism that the CIRB is going to use, and that's a compilation of the deviations to accompany the continuing review. Next slide. Now, there will be certainly confusion over what constitutes a minor deviation as opposed to a major, and then also what requires reporting. And the guidance document provides some guidance on this, but again, I anticipate there will be confusion. On all my slides, I've listed the ECOG-ACRIN email listserv where you can forward questions that may arise as to how to manage the minor deviations or what constitutes a reportable minor deviation. But let's start with the major. Majors I kind of, keep in the category of serious noncompliance, and those are deviations that will substantively impact safety, compromise trial integrity, or affect the participant's willingness to continue within the research. And those are somewhat clear, but not completely clear, because there can be overlap with minor. And then minor deviations are things like delays in visits or treatment, data delays or not getting data collection or secondary endpoints accomplished, or difficulties with special imaging or lab collections or PRO collection. Having care shifted to a different site, if it's all standard of care, protocol requirements like physical exams or routine laboratories, as long as they're done on time and according to the protocol, those will not constitute a deviation. It's only when they veer from the requirements of the study. Next slide, please. To assist with the minor deviations, we have developed a deviation log for you to use to track the deviations. These deviation logs will be protocol specific. And as I said, we're going to be soliciting them from you in anticipation of submitting our continuing reviews for these affected studies. This will start for protocols that have a continuing review that's due on or after July 15th. In turn, we're working on developing a master COVID-19 study and metadata array where you can access the study and the individual patients and can enter the deviations into a log there. So to try to facilitate this and ultimately make it easier when we have to submit our compilation of the deviations. We're probably going to have to come up with a different approach for TMIST and for MATCH. And again, I emphasize that all deviations must be documented in the research record. Next slide.
Thanks, Bruce. And now Matthias will discuss the remote consent process.
Well, thank you, Peter. Thank you, everybody, for joining us. We all have faced the difficulty of developing remote consent procedures over the years for certain trials where this was necessary. And one could say one good thing that came out of all of this tragic development is that we have now a defined remote consent process available through the NCI-CIRB. You probably have read some of the messages that were delivered to us by email by the CIRB from March 13th, March 23rd, and then most recently, March 23rd. And some of you have listened to Dr. McCaskill-Stevens when presenting at the recent NCORP meeting, when this potential for remote consent was offered and described. It was described in most detail at this very last message that we received from March 30th. And that's a bit tricky to find it in that way. It is titled Frequently Asked Questions Regarding COVID-19 and the CIRB. And here's some important scenarios are described in great detail, and I encourage you to read through all of them. And one of the very last questions that is being addressed is, can I utilize remote consent procedures at my site? And here, during this COVID-19 crisis, we are now permitted, it is active as we speak, to develop remote consent procedures. This is, of course, to limit the contact, to avoid patients to unnecessarily have to come to our centers to promote social distancing in response to COVID-19. We do not need CIRB approval for these remote consent procedures, but you need to update your study-specific worksheet or signatory institutional worksheet with the CIRB in order for them to know that we have applied, that we are utilizing these remote consent procedures. Now, with everything that we received from the CIRB, I would encourage that we follow this to the T. And this particular message, this last email from March 30th, gives us a very well-described, defined process. So basically, to go through this very quickly, the informed consent that is being conducted remotely basically is supposed to replace the in-person, face-to-face consenting process. Otherwise, it is identical to this process. So it's not any different and not done at lesser intensity and care. So keep that in mind. The idea is that we send the informed consent in advance of the discussion to the patient, to the participant, that we set up a phone video conference that is facilitating the communication, again, identical to an in-person meeting. It is advised that we have a witness present, and this is in part dependent on your institutional policy if a witness needs to be present for the consenting process. And if that witness needs to co-sign, this is not defined by the CIRB that this is a mandatory step, but a witness should be present, and the presence of the witness should be documented. In addition, we are asked to send a prepaid self-addressed envelope along with the informed consent if postal mail is chosen. Now, CIRB does not mandate that it has to be by postal mail. So electronic mail, email, other sorts of methods of transmitting this information can be chosen depending on institutional requirements. Once the informed consent received, the investigator received back from the patient. Once it is received, the investigator signs and dates the informed consent, and documents under the informed consent signature line a specific text. And in my slide, and of course in the CIRB communication email, it specifically says discussed with participant via telephone or video conferencing on insert date and received signed consent insert date. So it's a very specific text that we are now asked to place under the signature line, something we never were allowed to do, that we add something to an informed consent of this nature. This is now a required step. Next slide, please. So the documentation of the witness name should be done according to site-specific informed consent policies. The official date of the informed consent is when the investigator signs the informed consent form that was sent back by the patient that was previously signed by the participant and not, and to be very clear, the time of the actual informed consent. So keep that in mind. The signed informed consent is to be filed. A copy of it signed by the investigator, by the witness if appropriate, is being sent back to the participant. And to be very clear, no research activities related to study until all steps of this informed consent process are complete can be conducted. So keep that in mind. Additional concerns. Postal mail versus email versus electronic informed consent transmission can be pursued according to institutional guidelines. So for example, at ZRCare, we are not allowed to send these documents by email. It's not considered safe. So we have the option to send it by mail, or we're exploring right now within our EPIC electronic health record system to facilitate that through the MyChart feature. So it's something for each of your institutions to explore. Also, we need to send a HIPAA consent. Again, that portion is not defined, of course, by the CIRB. This is an institutional requirement. So we send that along with the informed consent. And again, that needs to be signed by the patient. The witness signature, again, is depending on your institutional guidelines. For example, at our institution, we do not require a witness to sign it, but for the CIRB requirements as outlined, it is important that we document that the witness was present and that we record his or her name. And then do not forget to update the SSW, SIW, as I earlier mentioned, indicating that you're now embarking on the remote consent procedures. At ZRCare, we have developed an SOP, remote consent. If you're interested in looking at our SOP and applying it maybe to your institution to save you some time, please send me an email or Noreen Wynn, our administrator of our Regional Cancer Center and Research Program. Thank you.
Thanks, Matthias. That was great. And we'll move forward now to emotional support resources for patients and staff from Lynn Wagner. Thanks, Lynn.
Hi, thanks for the opportunity to present. Today I'll be putting on my clinical psychologist hat, presenting on emotional support resources for patients with the goal of sharing information to also help providers mitigate the effects of the stressful challenges imposed by COVID-19. My recommendations are based in cognitive behavioral therapy, which is psychology's version of evidence-based medicine. Next slide. In broad terms, stress can be conceptualized as the dynamic balance between our perceived demands and perceived resources. We experience less stress when our resources outweigh or keep pace with our demands. As our demands exceed our resources, our stress level rises. Anxiety is a normal emotional response to a threat, and COVID-19 has threatened each and every one of us to our core. COVID-19 has added new and unique challenges and demands, as well as a great deal of uncertainty to an already stretched healthcare system, which is populated by a healthcare workforce teetering on professional burnout. COVID-19 has significantly increased work demands by elevating the medical complexity of caring for patients with cancer. Social distancing requirements have led to changes in workflow and the need to learn new processes and new technologies to deliver telemedicine, and also has resulted in us being physically disconnected from our patients and from our colleagues. Unknowns related to the course of the pandemic contribute to our demands by requiring constant adjustments to a shifting landscape. This novel virus introduces novel stressors. These changes are occurring in tandem with diminishing resources in the workplace, including reduced access to equipment intended to keep us safe, reduced staffing due to illness, and possible limits on access to medical equipment and medications. Many of these demands are out of our control. Therefore, with these increased demands, a good strategy to recalibrate the stress equation is to bolster one's resources. Next slide. Half the battle in managing stress is having an actionable plan. By separating out the controllable and uncontrollable aspects of a problem, you can tailor your strategy to focus on aspects that you can control. With regard to COVID, some examples of controllable aspects include sharpening your clinical skills, reducing your own risk of exposure when possible, and optimizing your own personal health through exercise, diet, and self-care. There are many aspects of this pandemic that are out of our control, including its course and the behavior of this novel virus. Many people get stuck when they dwell on uncontrollable aspects, which can lead to worry and rumination. The take-home point here is to first focus your attention on aspects in your control. Emotion-focused strategies can then be employed to help reduce stress, and some examples are listed here in the right column. When stress and anxiety get high, it can hit the reset button by purposefully redirecting your attention to the left side of the balance sheet and focus on things in your control. Next slide. Along those lines, this slide includes resources to help support your clinical practice. Many of you are probably already aware of the impressive COVID-19 Resource Center on the ASCO website, which includes information and webinars on patient care, provider and practice information, reimbursement and regulatory updates, and a community forum. The second bullet point is based on work by Dr. Anthony Beck, a professor at the University of Washington and a co-founder of Vital Talk, a nonprofit that provides resources to facilitate high-quality patient-provider communication. I've reviewed Dr. Beck's COVID-ready communication skills guide, and I was impressed by the thoughtfully written go-to language to address the many complex and difficult clinical scenarios that many of you providers will be or already have been facing in light of COVID-19. This guide is openly available for free through this web link provided. And the third bullet point is based on work by the Intensive Care Society. They have made posters and handouts available for free for distribution in clinical work settings to promote staff well-being and self-care during COVID-19. I reviewed the content and have been impressed. It's really nicely written. Next slide. Advances in technology have led to the rapid expansion in web-based programs and apps to promote health and self-management. I've listed 4 of what I think are the best programs here, which can provide benefit to patients as well as to healthcare providers. I strongly recommend one, the web-based program available for free through Shine and Mental Health America, available at virusanxiety.com. The site provides comprehensive education on health-related anxiety and a range of techniques and interactive exercises to promote adaptive coping skills and expand one's coping repertoire. The second listed here, Headspace, is a wonderful app to teach mindful meditation. Mindfulness is a very effective strategy to manage distressing symptoms, as well as to provide relief from anxiety about the future by focusing on the present. Headspace has added content titled Weathering the Storm, which is tailored to managing COVID-related stress. Also below Headspace, the Headspace screenshot, I'll highlight Calm, which the Calm app provides dozens of mindful meditation exercises as well as sleep stories, which offer an effective distraction from the worrisome thoughts that keep many of us up at night. Calm also provides diaphragmatic breathing exercises. Diaphragmatic breathing is deceptively simple in effectively engaging the parasympathetic branch of the autonomic nervous system to reverse the negative physiological effects of stress. The third site listed here, mentalhealthapps.org, provides access to e-health interventions that have been publicly funded and are now available for free. Last, I'd like to highlight the cancer support community as a wonderful resource for patients and their caregivers. In response to COVID, the cancer support community has expanded the hours for its toll-free support line. I also, not included on this slide, but also want to make a comment about the 800, the toll-free number for the suicide prevention line. Social isolation and hopelessness are 2 key drivers in completed suicides. And there is a toll-free 800 number, which is coverage 24/7. That number is 800-273-TALK, T-A-L-K. Next slide. In conclusion, this crisis has led to a much deeper appreciation for our healthcare workforce. Once this passes, we will have the opportunity to bring the importance of provider well-being to the forefront. I look forward to that day. Thank you very much.
That's great, Lynn. Thank you very much. And thank you for all of those resources. We're moving now to Al Benson's summary of interactions back and forth from the ACCC, Association of Community Cancer Centers, which may have some relevance for all of us. Al, over to you.
Thank you, Peter, and good afternoon, everyone. The ACCC members represent not only an extensive network of cancer programs across the country, but is unique in that the members include all disciplines in the cancer care team. Examples include social workers, pharmacists, nurses, physicians, and administrators, all of whom are very active in providing feedback to ACCC. The new president for this year of ACCC is Dr. Randy Oyer from Penn Medicine in Lancaster. And what's very appropriate for the cooperative groups, his presidential theme this year is entitled Community Oncology Can Close the Gap in Cancer Research. And Dr. Oyer was also very concerned about a 2019 ACCC survey that listed a number of challenges. And the three top challenges included 53% of people citing staff resources and training, 50% program infrastructure, and then also a lack of patient understanding of clinical trial processes. And all of these factors may be further stressed in terms of the current crisis we're experiencing. Next slide. ACCC recently had a webcast survey, and these were some of the points that were made during the survey, including that in terms of the research program, clinical coordinators were not allowed on site. In many cases, all new trials were halted. No new accruals were allowed. Many staff were redeployed or otherwise occupied. And some said it's simply not their top priority now. Next slide. There are some unchanged clinical trial principles that Dr. Oyer stressed during a recent webcast. These points included ensuring the safety of study participants is most paramount. Also, to try to continue the treatment trial when possible, understanding what are the goals of the treatment and not to compromise those goals whenever it is feasible. The importance of maintaining good clinical practices and to consult the sponsor and the IRB as needed. Also, the importance of determining alternatives for patient contact monitoring and drug access. And as I think Bruce emphasized, the importance to document extensively, particularly when you have deviations, and to document that this is because of the COVID-19 crisis. And ACCC also refers to the guidance documents that have been previously mentioned. Next slide. In terms of some of the trial trends in response to COVID-19, these were some of the observations made across ACCC, that new trials have decreased, some trials have been canceled. As Peter showed, there's decreased accrual to existing trials and delays in completion of existing trials. There's also more of an emphasis on continuing essential treatment trials. And also, in many cases, new COVID-focused trials are being designed and integrated in individual health systems. Audits, on-site visits, travel, and meetings, of course, have been suspended. And as time goes on, this may put added stress on our systems as we try to catch up when the crisis has resolved. people are looking at streamlined approaches as well as recording the deviations. And there are a number of solutions that are being considered. Certainly the widespread remote work environment and increasing use of telemedicine. Next slide. What Dr. Oyer mentioned, and this is my concluding slide, is emphasizing to stay safe and well, and I think Lynn captured that sense also. The importance of protecting your patients and your staff, certainly to maintain the focus on safety and to solve problems with your sponsor and your IRB, and again, to document, but also recognizing that this crisis may provide opportunities to look carefully how we've conducted research in the past and what changes have we developed, what have we learned from this that might integrate into our future research endeavors. And I've listed here the ACCC website, which provides an opportunity for commentary, but also can provide very helpful information. Thanks for your attention.
Great. So we're going to take on some Q&A, and I just want to remind everybody that although we've got a lot of questions up front that we can respond to, that there's still an opportunity to send in questions. So you can send them into townhall@ECOG-ACRIN.org. We're monitoring it. We can get some of the questions responded to at this point, or we can, if we don't have time, respond to them. We'll try to publish some responses to key themes and important questions. Can we go to the next slide with the first question? The first question, is there a pause on opening up new trials? And the answer is no. We're continuing to open up new trials, as they're appropriate. Obviously, we're looking at them on a case-by-case basis. We want to make sure these are trials that are important, that are appropriate for this, this time. And if there are things that are going to be really complicated in the trial that are going to require a lot of resource, a lot of attention, some of those trials we may look to delay. Obviously, trials, some of the ECOG-ACRIN related screening trials and things like that, we may also be delaying, but we are continuing to open up trials as we go along. Peter, any other comments on this? Oh. Well, I think we have Peter on still on mute. So why don't we go on to the next question? Next question relates to the spring meeting, and mentions studies continue to be activated. However, in most institutions, people are working at home. And a substantial portion, although they recognize the impact on patient care, is it safe to assume that the NCI-CRB is reviewing new studies, or these go to sites local IRBs? The CRB is continuing to review new studies, and so there's no change in oversight responsibility of the CIRB. It will be business as usual in terms of how the CIRB's role will be in the new studies. To be honest, I think they tend to act virtually anyway, so I don't think there's much of a change in how the CIRB will act given the COVID crisis. So it doesn't shift responsibilities to your local IRB. Next slide. Specimen collection, a wide variability in institution practices and what ECOG-ACRIN stance on that. Small sites are having limited resources in site. And maybe I'll ask Bruce, are you still with us? I wonder if you could give a response to how we're dealing with specimen collection on trials. Nope. Peter, you want to take this one?
Yeah, sure. I think that specimens are a very good example of how this is all being viewed from a regulatory and from a practical standpoint. The idea is to try and get the specimens if you can, but some specimens are more important than others. And the key ones are those that are critical to study outcome or to patient safety. They would need to be prioritized. But even then, some of the interim specimens cannot safely be obtained. And this is where the reports back to ECOG-ACRIN and later on to your IRB are really important. These don't require study amendments. They just require notifications. And it's a lot easier to make these notifications and to understand why specimens were missed at the time they were missed, rather than trying to piece together the story later. And this is what we're trying to set up for our membership. We're trying to set up processes that will make it easier ultimately.
Okay, can we go to the next question? Investigational drug pharmacists. Small satellites and rural sites potentially have only one pharmacist. If pharmacist is out due to illness or furlough and the drug cannot be dispensed for a cycle treatment, would that be a major or just a minor deviation during the pandemic? When site is completely dependent on one specially trained employee, it makes sites particularly vulnerable. My guess is the pharmacist scenario here is not the only one that will be similar to this. Again, I'll see. Is Bruce still around? Nope. Peter, why don't you take this one as well? Oh,
yeah, I can take it. And so the idea here is that you can't replace somebody for whom there's no replacement. So we may not be able to make things work, and there may be a deviation as a consequence of not being able to get the drug to the patient, and that's going to be life sometimes in this COVID environment. The issue is there are a couple of alternatives that are here. You could move the patient, you could send drugs by mail sometimes, but if it's a parenteral drug, that's not going to be possible. And patients may ultimately have to miss a dose. Is it major or minor? I think that's going to be less important. That's going to be a judgment call later. And believe me, we've been assured that any calls on major versus minor deviation are going to be very lenient indeed. It's really recognized that taking care of cancer patients, let alone taking care of them on a study, is a big lift right now.
Great, thanks, Peter. Can we go on to the next question? Guidance on data delinquencies, delays in scheduling follow-up visits or missed procedures and assignments. How should we document this? How will this impact performance? So this is another key question that Bruce could respond to, but I think he's having trouble with the mute function, so we can respond to that. So any delays that are directly related to COVID-19 or restrictions that are associated with COVID-19, while some will be considered deviations, no association to COVID-19 will be taken into account. So while we may require submissions of deviations more frequently, requesting deviation logs to COVID-19 be submitted within 1 month period when COVID-19 guidance is in effect. With respect to impact on performance monitoring, we will not be conducting quarterly performance monitoring scheduled for the spring 2020 quarter. We'll make an announcement later this week, but we're going to be very lenient how we deal with these, as Peter mentioned in previously. So we don't want people to be afraid to put patients on trials and to manage their trials because they're afraid that the limitations related to COVID-19 will create performance challenges that's going to hurt their institutional standing. So I just want to make that clear that we will work with you on that. We don't want people to not do the right thing because they're afraid there's going to be some administrative backlash. We go to the next slide. We received guidance about dispensing investigational pharmaceuticals, suggesting alternative delivery methods. How should sites handle investigative pharmaceutical return, since it requires a greater level of interaction and therefore exposure? Peter?
Yes. This is a really good question to which we didn't have an immediate and simple answer, because it depends very much on what kind of investigational product it is. Ideally, of course, the medicines would be returned to the issuing pharmacy. And of course, if you send it back to them in the mail right now, nobody's going to open the package for about 3 months. So, but we're not sure what the best strategy is for now. And so we put up the EA COVID-19 website here again, and we'll come up with a better answer for this in the next 48 hours. How's that?
That's a good one. And we'll send that around.
Peter and Mitch, one thing, so sorry I wasn't able to unmute my phone for some reason.
Oh, great. Thanks, Bruce.
One thing to keep in mind for COVID-related deviations, be they minor or major, our understanding is there will not be the expectation of a corrective action plan. So that's one of the reasons why it's important to document these things as COVID. If they're COVID-related, we still need to know about them and they still need to be handled, as I mentioned in my talk. But for COVID-related deviations, there won't be the expectation of a CAPA.
Great.
Thanks.
That's very helpful. So we're at 1:58, Peter. I think we probably ought to cut the questions off there. Thank everybody for their participation. Reminder, if you have any other questions that we didn't get to, you can send them to townhall@ECOG-ACRIN.org, and we'll try to publish any further answers in our published answers. And Peter, you want to come with the final words?
Just to say thank you very much for joining. Thanks to Donna and Jean MacDonald, particularly for setting this up and for making this broadcast work. And we appreciate everybody joining. And please feel free to contact Mitch or me directly if you have questions that you think we might actually be able to answer. This is a changing environment, and we'll continue to be in touch. Thanks a lot.
Great. Be well and be safe.
Thank you, everybody.